Welcome and thank you for tuning in to Derm Docs, powered by LiveDerm. This is the first of a 4-part educational series. This episode, entitled Steroidal versus Non-Steroidal Treatment, Case-by-Case Discussion, features board-certified dermatologists Dr. Mona Shahriari and Dr. James Song.
I'm Mona Shahriari, an associate professor of dermatology at Yale University and the associate director of clinical trials at CCD Research in Connecticut. And I'm joined by my good friend and colleague, Dr. James Song. James, glad to have you here. Why don't you introduce yourself?
Yeah, Mona, always a pleasure to be here with you. I practice at Mill Creek, Washington at Frontier Dermatology, and I'm currently serving as our co-chief medical officer, and I also run our clinical trial center. Great to be here.
So in this episode, we're going to focus on steroidal versus non-steroidal topicals for the management of AD. And I know you and I have these conversations all the time. So just to kick us off, when you're choosing between that topical corticosteroid, our old reliable, and one of these newer targeted non-steroidals for AD, what factors really weigh heavily in your decision-making?
I think broadly speaking, whether it's steroids or not, location matters a lot for me. It tells me, what can I use or can I not use? So if, for example, if I have a patient that has bad AD on the eyelid skin or maybe like the intertriginous or sensitive areas, now I may not necessarily want to use an ultra potent topical corticosteroid. I might want to use a lower potency steroid or try to go to a non-steroidal agent versus maybe a thicker like kinophi plaque on the ankle, or maybe more like a prurigo-like nodule. They sometimes could overlap with AD. Then I feel more comfortable with an ultra potent topical steroid. But also I'd say the severity of the disease, right? So we often refer to this kind of like an IgA. If a patient has like extremely red, swollen, inflamed, super itchy exudative eczema, I probably want to cool them off very quickly with the ultra potent steroid just for a couple of days, maybe to a week. Versus if it's more like a kind of like a low-grade, mildly itchy dermatitis that they get kind of every so often, I'm fine to go straight to a non-steroidal topical as well. And I think that speaks to a lot of kind of, are we addressing a flare or a maintenance? Because then we'll talk maybe a little bit more about that, Mona, as well. But for maintenance therapies, I'm generally going to want to use a non-steroidal topical versus a flare. I think now we're in a position where we can use non-steroidal topicals too, but historically, we've used a lot more topical steroids in that setting. And then, patient perception of steroids. Mona, I'd be curious to see how things are with you in your neck of the woods, but we have a really strong sense of steroid phobia. And so I actually do proactively ask my patients, how do you feel about corticosteroids? Have you used them before? And I try to feel them out whether I should start with that. But just curious, Mona, what do you think about that?
Well, I couldn't agree with you more. I'd say over the last 1 to 2 years is the first time where I actually have to ask a patient, I'm thinking of giving you a topical steroid. Is that something you're okay with? Historically, you just prescribe it and walk out of the room, but you're absolutely right. There is more steroid phobia, concerns about steroid withdrawal. And for some patients, it's not going to be an issue. But for others, given what they've gone through to get to that point, especially our AD patients who've been through so many different treatments by the time they make it to us, it's a real concern.
Yeah. And then when they hear that you're going to give them another steroid, they kind of look at you with a certain way. You're like, you're like one of those doctors or providers. So I try to be sensitive to that. I think age is also important, Mona. And maybe we'll talk a little bit about this later. But, I think kids, pediatric patients, are more susceptible to absorption from topicals that we're putting onto their skin because of their skin anatomy. So I really do try to limit ultra potent topical steroids as much as I can in the younger patient types. How do you feel about that?
Oh, definitely, especially if you're talking about your under 2 crowd because of the large body surface to volume ratio. I am concerned about HPA axis suppression, so I don't like the ultra high potency. And even with my higher potency ones, I try to be more cautious, keep that duration as short as possible. Like, I think both of us would agree when the topical corticosteroids hit the space, they were the best thing since sliced bread. But I think now we're starting to understand they do come with their own baggage that we have to consider for certain age groups.
Yeah, and Mona, you may have seen this study, and I was actually really surprised. They were looking at using steroids, topicals, in treating kids with atopic dermatitis. And one of the neat things with that study was that kids who used topical steroids had a lower likelihood of getting like allergies to hen or chicken. Chickens, they are shorter and they were smaller. They had lower BMI and their bone mineral density was also affected as well. And I think that was really kind of eye-opening to me, is that I'm not really measuring the height or the weight or routinely asking about the growth curve for these kids, but that's possible, right? With some of our steroid usage.
Exactly. If you are timing the steroid usage during those pivotal times of the child's growth, that in and of itself could potentially impact the growth even further.
Yeah, yeah.
So I think that's a really good transition into just, we know the topical corticosteroids have their benefits, but what do you think are the biggest strengths they kind of bring to our space right now?
They have been around for so long, Mona, right? They have a proven track record. I mean, they are a workhorse for a reason. I mean, pretty much anything that's inflammatory, we could probably get better with a topical steroid. And they have a lot of flexibility just because we have class 1 to class 7. So there is a strength that I think is appropriate for pretty much any single setting. It's just making sure patients are using it appropriately, right? And I think therein lies the problem, is that majority of people I have found are just prescribed a steroid, nothing else, and you're only told use this when you flare. But what about every other time, or during their maintenance, right? Or when they're not flaring, what do we do as well? So I think that is probably the main issue we have for steroids.
Yeah, and I do think the reliability that you touched upon, that's really important because when you prescribe a steroid, it's going to work. Now, long term, what the outlook is going to be is a completely different story. But I also think the fact that they're broadly anti-inflammatory makes them a little versatile for our toolbox, because you don't always have to know exactly what you're treating. I know we're talking about AD today, but maybe it's psoriasis, maybe it's some other form of inflammatory skin disease. If you put a steroid on it, it's probably going to treat it in the short term, and then you can come up with a long-term solution down the road. I also find access is generally good depending on the patient's insurance, like Medicare, Medicaid populations. I know some of the newer agents can be harder to access, but steroids for the most part are reliable. How has your experience been with access?
Yeah, I would echo that. I mean, I think if you do this enough, Mona, like you and I, we probably have figured out like what you need to do to get them on the medication. But truth be told, steroids often are a lot easier, at least if you're using some of like the triamcinolones or the hydrocortisones of the world. But I will say triamcinolone, I mean, it's really, really cheap, right? And it comes in a very large quantity. It's probably the most appropriate one if you do need to use it for a larger body surface area, because it comes in a 454-gram tub. And you could get it for a couple bucks even for your uninsured patients. So that and hydrocortisone 2.5% cream, very, very good bang for the buck.
Absolutely. And then I'm curious to know, what do you think of some of the limitations of the topical corticosteroids? Because if they were so great, we wouldn't have room for other agents in our space right now.
Yeah, yeah, and I think the side effects that we typically associate with long-term steroid usage, like skin thinning, atrophy, you get to really see those telangiectasias, acne sometimes as well. But we kind of touched upon this, the systemic absorption, right? And you mentioned this before, is that there was one study with clobetasol, and even just 2 weeks, it actually caused HPA axis suppression, which is actually kind of frightening. And then, we're starting to see studies about insulin resistance and major osteoporotic fractures being increased in people who use higher potency steroids for long periods of time. So, that is one of the main concerns. But also, it's what happens when you keep on using the medication is that your body kind of gets almost like resistant to it. I mean, I'm not sure if you've come across that, but you're like, I swear you used to respond to this one really well, and all of a sudden you're not. And then you try to switch to another one, and the same thing happens. And I think this kind of tachyphylaxis is real, and not necessarily something we see with non-steroidals. What's been your experience, Mona, with that?
No, I completely agree. And that's oftentimes why we have to limit the duration of the use. So it's partly because we don't want to overuse and cause cutaneous side effects, but also if they're using it every single day for 2 to 4 weeks straight, it's not going to work as well as it did on day one. So what I do in my practice is I actually have them use it 6 days a week and take one day off. I find that's easier for people to remember than 2 weeks on and 1 week off. But do you have a different approach to kind of get around the tachyphylaxis piece?
Yeah, actually, I really like that. I never thought about doing it that way, but I may steal that from you. I generally will do it like twice a day until they clear for 1 or 2 weeks, then to try to transition them to a TCI or something equivalent to use as proactive treatment. But I actually like what you just suggested there as well.
And I think the other piece, we both see a lot of patients with skin of color, and we both know they
Yeah.
don't love the white patches that are oftentimes left behind
Right.
because of a steroid. And we already talked about just kind of the age groups that you want to be a little bit more cautious in terms of using it. But even having this conversation right now, I'm sure some of our colleagues will say, but you know what? I love my steroids. They work so well and they're much better than anything else we have. But I think you and I have had this conversation that we tend to overestimate the efficacy of our topical corticosteroids. What do you think of that?
Yeah, 100%. And I think the steroids do work faster than some of our non-steroidals. I think ruxolitinib might be kind of the exception to that. But if a patient is willing to stick it through, however long, whether that's 4 weeks or 8 weeks, I really think the efficacy of these novel non-steroidal topicals are going to rival what we see with our actual steroids, right? It's just you got to give it enough time. And I think that's where setting expectations up front kind of is really important to set them up for success. But also, there's no one saying that you can't use a topical steroid for the first couple of days if you want. Going back to one of our earlier comments, if a patient has like terrible atopic dermatitis, like an IgA4, maybe I will use like a strong steroid in the morning and then a non-steroidal in the evening and just do that for like maybe the first couple of days or a week. And then you just have them transition straight to the non-steroidal topical. How have you kind of mixed and matched, or do you do that, Mona, at all?
Well, I think historically that was how I would do it, just to kind of
Yeah.
make the regimen as least complex as possible. But I think the complexity of some of our regimens, it's why I've started to step away from that. Because after we found out some of these limitations of our steroids, we shifted toward the older non-steroidals like tacrolimus, pimecrolimus, even crisaborole, because we thought, you know what, we do need this easier option that's better for maintenance. But I think we can both agree that though they were safe for the long-term use in all the affected areas, including the sensitive sites, they came with limitations like burning, local irritation, especially in areas like the face, the folds, and they were slower onset. So I found myself just kind of going back to exactly what you said. You use the steroid for the flares and then go back to the non-steroidal. But I can't tell you how many times the patient comes back after a couple of weeks. They don't remember what I told them to put where.
Oh,
And
yeah.
without a doubt, they put their ultra high potency steroid on their face, and guess what? It worked great.
Oh, yeah. Oh, yeah.
But
But
now
not
they have either a
necessarily.
patch of hypopigmentation or maybe they have a telangiectatic patch there. So
Yeah.
I was setting them up for failure.
I, I know. And, we do this day in and day out, but could you imagine someone for the first time, like you giving them 3, 4 different topicals, which is sometimes what I'm going to be handing them. And I look at what I'm writing for them. I'm like, oh my God, like I could barely understand this, let alone like, a non-trained dermatologist. So you're 100% right. I can't agree with that more.
So I guess there's definitely still an unmet need in this space
Yeah.
for newer agents. And I think that's where our next generation nonsteroidals like ruxolitinib, roflumilast, tapinarof have really aimed to fill this gap. How do you think these are now fitting into your toolbox? And do you think your algorithm has changed?
Yeah, I really do. And a lot of people refer to these newer agents as kind of like paradigm shifting. And I don't think that is that far of a reach, Mona. I mean, truly, the biggest issue with our topicals is compliance, like you just said, is either the complexity of the regimen or it's going to be the steroid phobia, or it's just the tolerability, right? But we have potentially the ability to truly have monotherapy for a lot of these patients, right? With any one of these three, I would feel very confident that if they stuck with the plan, it could be monotherapy. But it also offers those patients who are not systemic ready for whatever reason. Maybe they're just fearful of systemic therapies. Maybe their insurance companies aren't covering the systemic therapies. Potentially, these medicines can be used as a bridge or maybe even keep them from having to advance to a systemic therapy. And lastly, just using them as adjunctive therapies to patients who are already on systemic agents. I mean, until we get to the point where 100% of patients are getting to EASI 100, there's always going to be a need for topical therapies. And, you always kind of describe it this way. You kind of mop up the mess that's whatever left over with the systemic agents. I think that's perfect way to use these medicines, especially in those who have like persistent dermatitis on like the face or the eyelid or the neck or the hands even, right? Those are the times we might have to switch therapies altogether. but we hate switching systemics if we don't have to. And we have the ability to do that or to prevent those switches with some of these newer agents.
Yeah, I actually couldn't agree with you more because when it comes to certain systemics, we have patients who, for whatever reason, they think maybe their skin's not bad enough, or they have severe disease by the IGA criteria, but the BSA isn't really warranting or balancing out the side effects for them to go on a systemic agent. So I have had patients with these newer agents be able to delay the time to going on a systemic, or even there's sometimes delays in terms of getting the prior authorization. If you've waited 4 months to see me, you want to go home with something. And
Right.
some of these patients I've seen go on one of these non-steroidals, and then we decide, you know what, we may not even need the systemic because your skin has cleared up so much on the topical. But I loved your usage of them as an adjunct because let's face it, when it comes to AD, it's a waxing and waning disease, and no one's going to be 100% clear 100% of the time. So you need something to be that touch-up paint, so to speak, when we have those flares that break through. So yeah, I agree with you fully there.
It was actually touch-up paint that you used, not mopping up the mess, but same kind of touch-up paint. That's what it was. But
Won't relate to paint.
yeah. But it's interesting. Like when you compare AD to psoriasis, I would say that for psoriasis, our systemic therapies are so effective that many patients oftentimes don't feel like they need to use a topical, or they're okay with maybe a little bit of disease. But to your point, this is a waxing and waning disease, and it's very rare where I could have a patient just go straight on systemic therapy and not need to use anything topical. So I would argue every single systemic patient should still get a prescription for one of these non-steroidal topicals.
Definitely. And just to kind of go through them so our audience knows what we're
Yeah.
talking about, we have the topical ruxolitinib, which I think we can both agree the rapid itch relief has really
Yes.
been impressive, not only in clinic, but also in the clinical trials. And then you have topical roflumilast, which really has a robust anti-inflammatory action, especially in those sensitive sites. And then I think of tapinarof as an agent that has the potential for disease modification, where you have patients who can go off a drug and remain free of the AD or almost free of the AD for a period of time, a so-called remittive effect. Are there any other virtues of these that stand out to you?
Yeah, I think those pretty much, I would have said it exactly the same way. Ruxolitinib, extraordinarily fast. It's probably the fastest topical I've ever used. And they even went head to head against a mid-potency steroid. We just talked about triamcinolone, right? Showing that it's faster, deeper levels of itch and skin clearance. The one thing I think it is important to note, though, is that it's 12 and up right now, although that can change any day now. But they are also limited by like how much body surface area you can use it for and how long you can use it for. And probably one of the most frustrating things is not due to the drug's fault, it's the labeling, is you can't use it with systemic agents. Although Mona, you just authored a paper, right, looking at
So did you?
with systemic therapies that we can do it safely and effectively. But that is kind of the one asterisk, I would say, with ruxolitinib. And roflumilast, yeah, it's kind of like one of those set it and forget it type of therapies. There's like very little, and I don't want to score or minimize the safety here, but there's very little I worry about with this drug. I mean, I don't care where you use it. I don't care whether it's sebderm, AD, psoriasis, or anything inflammatory. I could just put it. And the vehicle is excellent, right? I mean, the vehicle itself is actually very effective for a lot of different conditions. And then, yeah, tapinarof, it's a really unique mechanism. It's the first one that we've seen of this kind. And like you said, it has this potential for remission where people stay clear for long periods of time, right? Much longer than we've historically seen with any topical. So yeah, I think all those these three topicals are really exciting in that regard.
Yeah, I like to think of them not really as steroid alternatives, but they're strategic choices that we're making every day in clinical practice. But what do you think these particular agents are doing for our patients from an adherence as well as a
Uh,
quality of life standpoint?
yeah, Steve Feldman, Mona, right? He always says the number one, two, and three reason why a topical doesn't work is compliance,
Yeah.
right? And I think that is absolutely true. Whether it's too complicated of a regimen, the tolerability issue, the steroid phobia, whatever the reason is that they're not being compliant, and unfortunately their disease isn't under control. So purely from a compliance standpoint, Mona, this has been really a game changer for my patients anyways. Much better compliance leads to much better long-term disease control, uh, generally lower steroid usage, which I think is a good thing. and then just improve safety and quality of life for these patients. So I think it's as simple as that for me. What about you, Mona?
No, absolutely. Because I think thus far I was giving my patients the steroidals combined with the older non-steroidals. The regimens were complex, and patients, they felt defeated when they'd come back to me. And when I would tell them they put the wrong cream in the wrong location, you could see it's like the teacher just told them they got an F. They felt so bad about what was going on. But now I kind of get the sense that not only are they being more compliant, but they feel like, you know what, I can do this. I can get my disease in check. I can control whatever it is that I'm dealing with from an inflammatory standpoint. And I think that's been huge for patients because we're not just clearing their skin, but we're potentially transforming their lives.
Yeah, I mean, I love that you're kind of just, you're empowering the patients to finally take control of their disease. Yeah, so I love that. Yeah.
Well, I think with all that background information, let's just take that info and apply it to some real cases. So
Yeah.
I'm going to just start us off with an 8-year-old African American girl who has atopic dermatitis primarily on the legs and the face. Her BSA is about 5%, but that 5% is moderate. She's tried and failed topical corticosteroids. And when we call it a failure, I think it's good for us to define what that means. And for her in particular, they work while she uses them, but the AD comes back as soon as she stops. But when I think of failure, there's a couple of other levels to it. If the skin is clear, but the itch isn't under control, that to me is still deemed a failure. Or maybe that treatment regimen is too cumbersome. That I would still consider a failure. And then she's left with these white marks where the cream was applied. She also tried a topical calcineurin inhibitor. It worked well on the legs, but left her face feeling greasy. And the regimens are too complicated and difficult to keep track of. She's 8. She wants to take control of her skincare regimen, but she kind of feels helpless with all the different creams and lotions and potions that we're sending her home with. And last but not least, the dark marks that the AD is leaving behind, especially on the face, are really distressing for her. So how would you approach her? What considerations would you keep in mind?
Yeah, this is very similar to, a lot of patients that I see. I mean, there's a number of different kind of issues here. First is they failed it because of inadequate efficacy. That's number one. I love how you talked about there's nuances or different levels to failure, right? So she's not responding because of the efficacy. She's having a hard time staying adherent to the medication because she doesn't like the vehicle, the TCI. And that's very similar in my situation too. Too complicated of a regimen for an 8-year-old. I mean, even for an adult, that's pretty complicated. And then this post-inflammatory pigmentary alteration, I mean, that's real, right? I mean, especially with our steroids. And so I think there's a lot of different things that we could potentially improve upon here now that we do have these newer agents. But I'm curious, Mona, kind of what was your thought process here? And then what did you end up doing for this patient?
Yeah, so everything that you said was echoing in my mind. And I really don't like topical corticosteroids in my skin color patients. And if I give it to them, it's going to be a very short course.
Yeah.
But I also want to cool down the itch as well as the AD quickly, because with every scratch, there's a potential for even more pigmentary sequelae. And she's someone who using a traditional non-steroidal just maybe wouldn't have given her the punch that she needed. So we discussed some of these novel next generation non-steroidals that she could use safely on the face and the legs. So it's one topical to treat anything head to toe for as long as she wants to. If something pops up in an area that I didn't know about and we didn't discuss, she can still safely use it in that area, and I'm not worried about overuse. And the thing that really resonated with me was she didn't like the greasy feeling of the calcineurin inhibitor that she had been on before. And so I was thinking she needs something that's a little bit more cosmetically elegant. And I did give her samples of topical tapinarof as well as roflumilast. You might ask why I didn't consider ruxolitinib, her age. She was not in the right age group for it. And I wanted her to pick the one she preferred. And interestingly, roflumilast was the one that she liked. And I think we both know that it has that unique crotophos that's found in cosmetic products, but it gives it that elegant feel. And to her, that was what she liked. But sometimes you give the patient the option to pick their own adventure, so to speak.
Yeah, I actually do the same thing. I would hand them out actually the different samples that I have in the office. I'm like, you pick. And, I actually want to have them wait around for a little bit to see, does it burn? Does it sting? And I think those are both excellent options. Their tolerability is great, but I would echo what you said about roflumilast, and that the secret sauce really is the vehicle. I mean, the active ingredient is absolutely important, but I mean, you can use the vehicle itself, I feel like, as a medication. And we've seen that pretty consistently across all the trials for the different indications. The vehicle works really well too. I don't think that's a knock on the drug. I think that's a strength of the treatment, right? Is that the vehicle works very, very well. So 100% agree here. I'd be curious though, if this patient, if he did have a 2 and over indication for ruxolitinib, would this patient have been an appropriate candidate for you to start?
They would have, especially when we want that itch to calm down yesterday. I think that speed of efficacy that we can expect with topical ruxolitinib would have definitely come front and center. The only thing that would have made me have a conversation is the twice a day dosing versus the once a day dosing. So for her, maybe twice a day just doesn't fit in with her lifestyle, but it's also possible I tell her to do it twice a day for the first 2 weeks, we cool it down, and then maybe she can back off to once a day. That's kind of the art of medicine. That's not exactly what the label intended, and that's not how it was studied. But we know in the real world, patients will do what they want.
Absolutely, absolutely. So that's actually a very great point. I think once daily, generally more compliant than twice daily. So that can sometimes be an issue, but it works so quickly. Yeah, you may only need to do that for a couple of days and you could kind of back off. I had a similar story to this, Mona, but this patient kind of kept reacting to every single topical I gave her. It wasn't an obvious reaction, but she would say it felt better initially and it would just come right back, sometimes even angrier. And actually, the patient was a little older, but I had them on tapinarof as well as actually ruxolitinib. And then we patch tested this patient and the 2+ to propylene glycol. And so this was the patient where, roflumilast made a lot of sense because, this was the only one that didn't have actually PG as one of his excipients. And so that's just kind of one thing I learned from treating these types of patients is if they don't respond the way that you think they should respond, you either have a wrong diagnosis, they're not compliant, or they might be actually allergic to either the active ingredient or one of the excipients.
I couldn't agree with you more because I think the allergic contact dermatitis that comes from some of these topicals that we use, especially our AD patients who are going through so many different topicals, putting neosporin on some of their open wounds, I do think it's more prevalent. And as derms, we don't always remember that's an important thing to keep in mind. So I'm glad you brought that up.
Yeah.
And let's talk about another patient, a 36-year-old white male, recurrent atopic dermatitis, predominantly on the head and neck area, BSA 10%, IgA also moderate, and tried and failed topical corticosteroids, calcineurin inhibitors. Now, he was fearful about the side effects of a systemic. He was also worried about the overuse of topical corticosteroids on the face and the neck, so he doesn't know what he wants to do. But he had a significant psychosocial burden. This is on his face, it's in a very visible area, made him self-conscious, embarrassed to go on dates. And in terms of considerations, how would you approach this patient?
Yeah, I actually would, brought up systemic therapy to this patient. And obviously, it sounds like he's had that conversation already and he's not comfortable with it. But I think this case really illustrates that up until we've had these novel non-steroidal topicals like the ones that we've discussed, if they don't respond to TCS and TCI and they don't want to go on a systemic, what are your options, right? Like phototherapy, maybe, but I don't love phototherapy on the face and neck. I mean, oftentimes it flares it initially when they're this acutely inflamed. And, we refer to these areas kind of as high impact areas because even, Mona, if the BSA was half of that, like 5%, right, you can still say that might bother the patient more than someone that had like much higher BSA. So I think this is a tough case, but fortunately, it's not as tough as it was before, Mona, because several other therapies that we can try here as well. But also, I would say a pretty common scenario for me. And I often do find that, especially in the face and neck area, they're often just smattering so many different things on here, right? So they probably have a secondary irritant, maybe an allergic contact dermatitis as well.
No, absolutely. And I think for someone who isn't ready to jump on the bandwagon for a systemic agent, giving them the best systemics we have that are giving the best topicals that we have that are easy to use is a good way to kind of maybe prove to them that, this is the best that it's going to get. And if we're not getting to where you need to be, then we can talk about the systemic. So what I do in clinical practice is I give them 4 to 6 weeks of one of these novel non-steroidals. And in this case, we did talk about all of the different agents agents in the landscape, all three, ruxolitinib, tapinarof, and roflumilast, because he was a candidate for all of them. And in 4 to 6 weeks, I saw him back. And at that point, he wasn't where he needed to be. But I think having tried it and proven to himself that, you know what, I gave the topical a good go and I didn't get the results I'm looking for, that made him more likely to want to start a systemic agent. In terms of safety, are there any call-outs that you would discuss with him, given how nervous he was to go on a topical corticosteroid, let alone a systemic?
Yeah. So I try to read the patient first and and if they're really risk averse, which it sounds like this patient is, then I do think it's worthwhile to spend a little bit more time up front so that you could kind of control the narrative, right? So like you said, they don't Google it. But, I generally will say, look, just because something happens doesn't mean it's a side effect. It just simply means it happened after it started. And many of these things can happen even in people who don't take the medication. But, if you were to start from the top, I would say with ruxolitinib, for example, we do see a little bit of acne. It's more so in the vitiligo studies than in atopic dermatitis, but that is a on-target effect of JAK inhibitors. So I do mention that. As far as for tapinarof, probably one thing that I will point out is folliculitis. And we've seen this pretty consistently across the different clinical trials, much less so in AD than in psoriasis. And, I don't know how it has been in your experience, but it's certainly not 9-10% of my patients. I think with proper counseling and not overusing it, the rates are much, much lower. But I do like to call that out just because if it does happen, I just tell them to take a break. And then generally that's all it requires, or like a little bit of like an irritation from using it, although the rates are pretty low. And then with roflumilast, just, being a PDE4 inhibitor, there are certain adverse events of interest that we like to kind of just at least mention. But generally it is in people who are using it in much higher body surface areas, whereas those who use it in low BSAs, generally you're not really seeing the headache, the nausea, the diarrhea, and then the burning and stinging is actually quite low as well. Curious, anything else that you would add to that, Mona, as far as like when you're counseling patients about one of these agents?
Well, I feel like when these agents and really
Yeah.
talk to them about everything that you just mentioned, I'm finding I don't get phone calls about these issues as often as I thought I would. Because again, with our first generation non-steroidals, that burning, the tolerability piece, that was real. We would get so many phone calls. So I've basically started to do a much more watered down approach. And I say, you know what, anytime I give you anything new, there might be something that doesn't feel right. So call me if you feel any sensations on your skin or there's something else going on that's out of the ordinary. But I give them that kind of overarching way that they can give me a call about anything that may come up, because I'm not really seeing those specific AEs that I thought would be a problem. Even the folliculitis, like you said, I don't see it as often, but I have seen it in clinical practice. I don't even bring it up as something that they may develop. I just say, you know what, call me. And then if they call me and say I have these bumps, I'm like, you know what, that's probably the cream. We need to take a break from it. For
Yeah.
this, you mentioned the overuse of some of these topicals, and I really like that point because we're used to everything being twice a day in dermatology. And I can't tell you how many times for topical roflumilast, topical tapinarof, my staff has changed the directions in my EMR to twice a day instead of once a day. And not only do we have to clarify it with the pharmacy, but the patient themselves sometimes doesn't even read the tube and overuses it. So that in and of itself can lead to AEs that were unintended. But the studies really showed great local tolerability, low irritation scores, and not only patient reported, but also prescriber assessed, which I think has really shown us the value that these bring to the space.
Yeah, that's a great point. And I've run into those issues too. It's just like out of habit, everything's BID. And sometimes when I see patients apply it in front of me, like when I give them a sample, I'm like, that is way, way too much. They're like using it like a moisturizer, right? So I'm like, it's not cake frosting, guys. It's like, I forget who described it this way. It's like paint within the lines, right? That's how I use. And I actually will show them, Mona, like your fingertip unit from the tip to the crease, that's one fingertip unit. That should be enough for 2 palm prints. And I think if I explain it that way, they're like, oh, okay, well, I really don't have to use as much as I thought. And those tubes, even though they're all 60-gram tubes, they go a long time, right? Because once you're better, you can take a break for them for a while. And so I think we've been pleasantly surprised with all of them. One thing, Mona, I will say, I love how this case that you shared isn't like your cookie cutter kind of like, we know what's going to happen at the end of the story type of right case. I mean, this is real world. Okay? And I've had patients like this as well. But I think the fact that we've tried, we had options, And sometimes it doesn't always work out, but I would say that there might be instances where it does work out. And then even if this patient ultimately does advance to a systemic therapy, like we said before, he's still going to probably need to use a topical anyways. And the fact that he's had a positive experience from it probably makes him feel comfortable to use it if he needs to in the future, in addition to the topical or the systemic agent.
Exactly. And especially roflumilast and tapinarof, there's nothing on their label that says you cannot use it with a systemic. So from an access standpoint, it should not be an issue. But as you discussed earlier, we have real world data that shows combining topical Rux with a systemic doesn't have much issues from a safety standpoint either. So definitely great options for our patients. And one other thing, just from a moisturizing atopic dermatitis standpoint, I know we were briefly talking about the vehicle for roflumilast. One thing I love is how hydrating it is. And I didn't realize that they had actually gone head to head with a leading moisturizer, and it was pretty comparable. And that to me, I think really affirms what I've felt all along when I've used the vehicle in clinical practice when I didn't have my moisturizer around. Like it can make a difference, but for our AD patients especially, I think that's a bonus.
That's a great point, and I feel like that's not something that gets talked about enough, but you're absolutely right. When they did that study and measured transepidermal water loss, like I was super impressed by that too. I'm like, heck, you can use this like a moisturizer. Absolutely.
Exactly. Well, I know we have gone through a lot, and I always enjoy having conversations with you, James. I learn something new every time. But looking ahead, how do you envision these next generation targeted topicals really changing the everyday management of atopic dermatitis?
It's an exciting time, right, to be treating these diseases. And I'm not trying to say that we have now, or we should replace topical steroids altogether, but because they're always going to have a place. But what I do hope is that these non-steroidal topicals will really become our first line agent for our patients with atopic dermatitis. And we're going to move away from just treating AD episodically, but we're going to be treating it proactively rather than reactively. And that patients, like you said, Mona, will be empowered and they'll feel confident and comfortable in being able to manage their disease without worrying about, am I doing this right or wrong? And can I use it here or not there? And I think ultimately that's going to be a win-win for everybody because patients ultimately will just have a better outcome.
Absolutely. And I think with all the conversations about steroid stewardship and what we need to be doing as a specialty to really set an example on how to appropriately use the topical corticosteroids, I do hope our colleagues shift toward these non-steroidals becoming more of that first line agent. Obviously, access, the insurance piece, we all know is going to be the number one barrier for that kind of a change. But with time, I think the more we use them, the more insurance companies will start to realize the value, and it could even have cost-saving benefits in the long run.
Couldn't agree with that more. Yeah.
All right. Well, thank you again, James, and thank you to our audience for tuning in, and join us on our next episode.
Thanks, everyone. Yeah.
Stay tuned to Derm Docs, powered by LiveDerm, for more dermatology education coming to you soon.